great pleasure in presenting Dr. Archana Areti from Pondicherry, India, currently working as an assistant professor in the Department of Anesthesia at Mahatma Gandhi Medical College and Research Institute. Her interest is in ultrasound-guided techniques and management of acute pain. She's a society member of ISA, AWARA, and she's also an executive committee member of AWARA.
Good evening. In this How I Do It session, we'll be discussing about brachial plexus blocks and our insight into it. So let me start by talking about how we do brachial plexus blocks in our institute. First and foremost, we strategize. We spend a little time discussing about which strategy and which approach to use for which patient and situation. Then we perform systematic ultrasound scanning and try to identify all the individual elements of the brachial plexus above the clavicle, followed by performance of targeted and selective blocks which are tailored to the surgical requirement. And we use only about 8 to 10 to 12 ml of local anesthetic, the choice based on the preference of the anesthetist that is performing the block, and of course the requirement for the surgery. So how did we arrive at this understanding of brachial plexus? This is an amalgamation of the work over the last 2 to 3 years in our institute, where we've come to identify what are the actual elements that are present above the clavicle. So just first and foremost, there are 5 roots, that is the C5 to T1. There are 3 trunks, the upper, middle and lower trunks. There are divisions, which can be from the upper and the middle trunk. And also there are 4 branches, that is the dorsal scapular, the long thoracic, the suprascapular nerve, and the nerve to subclavius. How did we come about identifying all of these elements? Well, first of all, we went back to the anatomy dissection hall, and with the help of our anatomist who has done the dissection here, we have actually explored where is the extent and situation of the brachial plexus in its interscalene groove, and also its relation to the surrounding structures and how it's situated. So from this image, you can see after the dissection of the superficial structures and the muscles covering the brachial plexus, you can see there is the middle scalene right here, there is the anterior scalene here, and this is the interscalene groove with the brachial plexus contained in it. Now, another interesting thing here to see is the presence of the phrenic nerve, which you can see here, that is present in close relation to the brachial plexus on top of the anterior scalene muscle. So this is a traditional way of dissection. Over these last 2 years, we've also tried to gain understanding through obtaining oblique cut sections. So this is how we view the sonograms of the brachial plexus when we do the scans. So we try to corroborate the gross anatomy to the sonoanatomy, and we were able to identify individually and confirm that these were the elements that we could see. More details of this process of dissection and identification with the corroborative findings you can find in this video which we have prepared and uploaded in YouTube. So now once we were able to identify and name all the elements above the clavicle, we went ahead and also proposed a few signs for scanning and identification of these things during dynamic ultrasound scans. So to start with, when you are scanning individual elements to identify them, we start with the roots. So we'll start with the C5. You can see a sonoanatomy picture over here with the C5 root when it is coming out of the transverse process. This is represented by a line diagram here, as you can see, where this M-shaped or wave-shaped, it's a double mountain, you can also call it, and this appears like a sun rising out of. So the mountain is basically represented by an anterior tubercle and a posterior tubercle of the transverse process. So this is how we identify the C5. Follow it up with the C6, which is also appears to rise out of 2 mountains. But here the difference between the C5 and C6 is the C6 is a little bit bigger, you can see, compared to the C5. and also the anterior tubercle is much more prominent than it is in the C5. Then the C7 also has its unique sonoanatomy pattern where it only has a posterior tubercle with no anterior tubercle, and also this is the level at which you can clearly see the vertebral artery. Then you come to the C8, where you can see it over here, over the first rib. This is now lateral to the subclavian artery, and in fact this is the interscalene groove above it, the anterior scalene muscle and the middle scalene muscle, followed by the T1. This is the last root, where you can see the rib moving to the left here, that is laterally and away from the artery. The C8 has just moved up, and then you can see the small little T1 root that's just popping out from below the rib, I should say above the pleura, and it moves up to join the C8. So this is the basic identification of all the roots. These are all, you have to understand that they are clearly visible in dynamic scans and not in static images. So always remember to follow a traceback method when trying to identify them. So you can hear here in this video where when you're dynamically running through the scans, this is the C5 followed by the C6 with its prominent anterior tubercle, followed by the C7 with its absent anterior tubercle and only a posterior tubercle. You can also see the vertebral artery clearly, followed by the C8, which is appearing above the rib, the first rib, followed by the rib moving laterally, and then the small T1 just drumming out of it, moving up to sit on the superior surface of the first rib. So this sign for the T1, we've termed it as a U-turn sign, where it appears as if when it comes from below the first rib, and then as you move more distally, it takes a turn around the rib and comes on top of the first rib. So it's a paradoxical sign actually, where you know that it's not actually going backwards, but on the scan it appears as if it is. So that is why we call it a U-turn sign. Now once the roots are all identified, it's just a matter of tracing them till they form the trunks. So you can see here the C5 and C6 form the upper trunk. The C7 alone transforms into the middle trunk. And then as you scan more distally, the C8 and T1 after the U-turn, they both combine to form the inferior trunk. So this is how the trunks are formed. The upper trunk, so how do you differentiate the roots to the trunks? Well, here you see they are hypoechoic and round, but once they become trunks, they have multiple honeycomb structure with, so that is the connective tissue that you can see, which is adhesive. Also, the other thing you can see, the upper trunk has divided into the anterior and posterior divisions with the suprascapular nerve. So now once you've identified all the structures you wanted to identify, it's about performing the block. So in our institute, we follow this targeted truncal approach where we approach each trunk individually and deposit some amount of local anesthetic in each trunk. You can see these are meticulously done. These are high-level advanced blocks, so a lot of practice is required before performing them. It requires a lot of skill control with your needling. You can see now this is the injection into the middle trunk with a little bit of local anesthetic here. The previous one was the upper trunk, and now this one is the inferior trunk, where you can see this is an out of plane needling technique with in the corner pocket you see here, and on top of the rib, this is the inferior trunk, and this is the local anesthetic being deposited around it. So this is how we perform our targeted truncal injections. Now each little splurt of local anesthesia spread that you can see, the volume there basically is around only 0.5 ml Alicol. So every single small injection that we do, we increase the amount by about 0.5 ml. So the actual volumes that we use, and this is based on a study that we've done in our institute, and their findings were that mostly for each, the upper trunk and middle trunk, around 3 ml is sufficient, whereas for the inferior trunk, it takes about 4 to 5 ml. This gives us at least 3 hours of surgical anesthesia and 6 hours of analgesia. So these are the findings of this study. Apart from that, how am I able to tell you that these blocks are all selective and they're not involving the entire of the brachial plexus? Well, we do a combined assessment technique of sensory and motor and try to isolate which roots are involved and which are spared. So this is just a small video showing an assessment of the block after performing an upper trunk block. So this here you can see here, that's the dermatomal supply, and here the patient is trying to move his shoulder but he's unable to, and he's not able to flex his elbow also, so that is a blockage of the musculocutaneous, which is again C5 and C6. And then, but the distal arm movements and wrist movements are all intact. So this is how we are able to say that our block is selective, our shoulder is blocked, the elbow flexion is blocked, but the distal movements of the hand are not. So to summarize, to gain a proper insight and understanding into brachial plexus blocks, it's always good, first of all, to get back to the basics and understand the entire anatomy and formation. Learn the fundamentals of ultrasound scanning, image acquisition, and image interpretation of the brachial plexus. And also, practice makes perfect.